Respected IADVL members, revered faculty, and dear postgraduates, on behalf of IADVL AP, we are conducting these PG clinics. The aim is to strengthen the clinical skills of postgraduates. This is our 9th consecutive PG clinic. The previous we did on long cases, short cases, spotters, instruments. And today is very special with Dr. B.V. Ramachandra sir from Jim Sir, Vizag. So he accepted our request to conduct these PG clinics. Sir is our internal examiner for today. And our external examiner is Dr. Chidambaramurthy, HOD of Bellary. And the presenters are Dr. Aditya Chitturi, Dr. Sanket, and Dr. Krishna Priya. All the best, dear postgraduates. And I invite Dr. Kavita to give the presidential address.
Good afternoon. Warm welcome to all of you. At the outset, I thank Dr. B.V. Ramchandra sir and Dr. Chidambaramurthy sir for being our examiners for today. I can promise that it's going to be a wonderful academic feast with great teachers on board. And I take this opportunity to invite you all for our QTCon that is being held at Guntur on November 30th and December 1st. Please finish your registrations, and all the postgraduates will submit their abstracts for free papers, for posters, award papers, and the last date is October 15th. And I invite all the practitioners, assistant professors and associate professors below 48 years of age to submit their abstracts for blooming dermats. The young dermatologists can take this platform to present their original studies or their work to be as speakers for the conference. So you can submit your abstracts before October 15th. So I hand over the proceedings to Saujanya and take this, all the pages, you can take this as another wonderful academic feast. Thank you all.
Thank you, madam. Rohit, can you please project the CV of Dr. Ramchandra sir and Dr. Chidambaramurthy? Thank you. Our internal examiner is Dr. B.V. Ramchandra. I'm very happy. As sir was my teacher, he was my associate professor during my postgraduate days. He is at present the professor and HOD of Geetham Institute of Medical College and Research, Visakhapatnam. He has 30 publications to his credit. And he is awarded, this year he got 2 awards, Best Teacher Award at South Zone at Dermacon 2024. And he is facilitated with Lifetime Achievement Award at APQTCon 2023 Eluru. He was awarded Guru Puraskaram at Basics for Dermatology Symposium, and he was the president of APQTCon 2016 conducted at Eluru. He is the chairman of Scientific Committee APQTCon 2011, and almost all the conferences conducted at Vizag, sir was the scientific chairperson. And he is the organizing secretary of and the president of AP branch at 2015 to 16, and is the secretary of AP branch of 1999 to 2000. He is a member of GSK Forum of Hyderabad chapter, and he is the examiner and an MD paper setter for many medical colleges and also an MCI inspector. He conducted many drug trials for Novartis and Lotus Laboratories, and his areas of interest are autoimmune diseases and leprosy. Can we move over to the next slide, please? Dr. Chidambaramurthy is the professor and HOD of the Department of DVL, Bellary Medical College and Research Center, Bellary. He has 50 publications in national and international journals to his credit, and he wrote 5 chapters in various textbooks. He's on the editorial board of Indian Journal of Drugs and Dermatology, and a reviewer for JPGM, CDR, IJD, PTD, and clinical cases. Thank you, sir. Over to you, sir.
Thank you. Let me thank our president, Dr. Ratota Kavita, and Dr. Saujanya for bringing me into this program. And I also thank Dr. Chidambaramurthy, our external, who readily accepted our invitation being part of this activity. I welcome all the postgraduates and staff members of different colleges, and then welcome to all, and let us straight away start the program. And we have we envisage all spotters, and then we have three candidates. All three are the postgraduates: Dr. Aditya, Dr. Priya, and Dr. Sanket. They are postgraduate students, and they are taking examination this December. And so we have about 6 spotters. Each spotter we can ask for 10 minutes, that is 60 minutes. And we have differential diagnosis, 3 cases, 3 set of cases. And then each 5 minutes, that is about 15 minutes. And we have about rapid fire session, 10 of them, and then all students will participate. And there are no marks. And then our objective is not to get into the level of knowledge and the depth of the knowledge of our postgraduate students. Right. So, shall I start?
Yes.
Round 1. Shall I start?
Yes, sir.
Murthy garu?
Yes, sir.
Right.
Start.
Spotters. This is spotter 1. Goes to Aditya.
So,
So,
good morning. Good afternoon, sir.
Yes.
So, shall I start, sir?
Yes.
Sir, here I
First
can see.
describe the lesions first and then start with the diagnosis.
Okay, sir. So here I can see multiple well-defined patches of alopecia, sir, which are having skin colored and smooth, and all these are forming a confluent and large patch, and without any inflammation or any scarring or any atrophy or any erythema or any scaling, sir. So mostly I'm thinking it may be a non-cicatricial alopecia without any inflammation or any scarring, sorry, without any inflammation or any scaling. So my first differential I'll be keeping a alopecia areata, sir, and second differential I'll be keeping either pseudopelade Brock or any other cicatricial alopecias, and then tinea capitis or trichotillomania, sir.
You only told that there is no scaling and other things.
Yes, sir, but
So why do you want to give tinea capitis as differential diagnosis? And that is not there. When there is no evident scaling or any other obvious signs of inflammation.
So because
so how
in
do you justify your diagnosis as tinea capitis as differential?
Sir, because in black dot type of tinea capitis, there will not be any inflammation, and these black dots are also a feature of alopecia areata, sir. So we need to carefully differentiate whether
Black dots you see on dermoscopy, but
yes,
on superficial examination, what you see is, if you see still on the right, if you see on the temporoparietal region, if you see
yes,
there is another patch which is present. So you can see that one more small patch is there, which is adjoining to that large patch.
yes,
Can you see that?
yes, sir.
So now you can tell clinically that it could be most likely alopecia areata, which is coalescing to form without any inflammation and all. Isn't it? So
yes,
patches might have progressed to result in alopecia areata.
yes,
So now we were first diagnosis was alopecia areata.
yes, sir.
So coming to that, so what is basically alopecia areata?
Sir, alopecia areata is a chronic inflammatory condition. It's a non-cicatricial alopecia.
It is non-inflammatory condition, and you are again telling that this chronic inflammatory.
Sir, like inflammatory condition because it is occurring due to
histologically it's inflammatory.
Clinically, no signs.
Clinically, no signs of inflammation.
Characterized by sudden onset of smooth non-cicatricial alopecia, sir, commonly on the scalp, but can involve the other areas like fibros and other body parts also.
Okay. Can you highlight the pathogenesis of alopecia areata?
So the pathogens mainly we have got the genetic factors, environmental factors, autoimmunity, but the main thing depends upon the maintenance of the follicular immune privilege. If it is disrupted, it leads to alopecia areata. So initially, whenever a genetically predisposed individual has environmental factors like either the psychological stress or infections like hepatitis B or cytomegalovirus or swine flu or any other vitamin D deficiencies or any other iron, zinc, manganese deficiencies or or can also be due to heavy metals and the drugs like dupilumab and other drugs. Whenever there is there, it causes a inflammatory response, producing the interferon gamma and other inflammatory markers, which activates the CD4 receptors by JAK-STAT pathway. Thereby, it forms an infiltrate of lymphohistiocytic infiltrate and a mast cell infiltrate, which is mainly present in the peribulbar area,
Which cells are
where
present?
we can see.
Which cells
Sir?
are present predominantly?
CD4 cells. CD4 T cells are main cells.
CD8 or CD4?
CD4 cells. CD4 cells.
There is an altered ratio of.
There's an altered ratio, like the main
CD4 and CD8.
CD4 ratio is increased, sir. Like it becomes 4:1.
CD8
CD4
ratio is increased. Actually, CD8 inflammatory infiltrate is increased, and there is an alteration in the ratio of CD8 to CD4, and that can result in this one. Okay. So now you, in this case, in the spotter which you are seeing,
yes.
what type of alopecia areata it could be? What you would like to name it as? Which type of alopecia areata?
Sir, I'll name it as alopecia localis. Sir.
No. Localized, because localized means it should be patchy. Now you are seeing that it is all coalesced. And which area is involved?
Mainly the vertex area.
Vertex and
other
areas.
Vertex and other frontoparietal area. So it may be going into subtotalis also.
No, it is resembling that of androgenetic alopecia, isn't it? Androgenetic alopecia like alopecia areata.
Incognito.
So what it is?
Alopecia areata incognito.
No. Alopecia areata?
Incognito.
Now we only got stuck. You tell me what is alopecia areata incognito?
Alopecia areata incognito is a condition where it commonly resembles like a telogen effluvium or androgenetic alopecia. There will be
diffuse hair loss.
Diffuse hair loss.
Diffuse hair loss will be there. It is of sudden onset, and there is no patches which are present, and it is difficult to differentiate it unless you do a dermoscopy or if you do a histopathology. So on histopathology, you can make out that there is a that lymphocytic infiltrate which is present, and that can show you that. But this doesn't resemble that, because you are seeing patch. In that there won't be patches. In alopecia areata incognito, there won't be any patches, isn't it? So here you are seeing patches which are present. So it is resembling almost androgenetic alopecia, which is occurring in the early stage. So it can be reverse of uphiasis, that is Cisapo type. Okay, so that can be a Cisapo type of this one. So what are the clinical variants of alopecia areata?
The clinical variants are, sir, one is the alopecia localis, alopecia subtotalis, alopecia totalis, and universalis, sir, and then Cisapo ophiacis, and then linear type of alopecia, and then perinevoid, and then acute and diffuse type, sir, and then alopecia incognitos.
Okay, so you have heard of Ikada's classification, isn't it?
In Ikada's, there are 4 types are there, sir. One is the common type, and then the atopic type, and then autoimmune type, and the prehypertensive types.
Okay. So what are the predisposing factors for alopecia areata?
Sir, the predisposing factors like mainly a patient like already the predisposing factors like other autoimmune conditions like any Hashimoto's thyroiditis or pernicious anemia or psoriasis lichen planus. All these autoimmune conditions and atopy can progress to alopecia areata. And any psychological stress, all these can predispose.
Okay.
Aditya, the patient will ask you what would be the prognosis of the disease, whether he is going to respond or not. So how do you assess, and what's your answer?
Sir, the prognosis mainly we have got few poor prognostic factors, sir. Like normally, whenever it is a limited type of alopecia areata, it gets resolved within 1 year, sir.
You tell some of the poor prognostic factors in alopecia areata.
50% of the time, but more if it is involving the poor prognostic factors, sir, young age group, younger age group, family history of atopy, sir, and along with that involving more than 50% area, atypical variants like Cisapo ophiacis, and then involvement of eyelashes, eyebrows, nail involvement, and
what kind of nail involvement?
Sir, nail involvement, the characteristic feature is the multiple shallow nail stippling type of nail pits, which are arranged in a geometric fashion in longitudinal grids and horizontal grids, sir, giving the appearance Scotch plate patterns. Other than that, we have got nail thinning, then onycholysis, onychometasis, trachonicia, Bu's lines, and punctate leukonychia and red lunula. All these features are also seen.
Is trachonic a specific feature of alopecia areata?
Sir, it's like it can also be seen in other conditions also, sir. Like
It's not
lichen
a
planus.
specific feature
Not
of
specific
alopecia
feature.
areata. So you know that alopecia areata is supposed to be a autoimmune disease, isn't it?
Yes,
So what are the
autoimmune.
other conditions which can be associated?
The other autoimmune diseases it can be associated as, sir.
You
One
can
is the
classify it as cutaneous and systemic.
Okay. So, in cutaneous, we have got psoriasis, lichen planus, vitiligo, sir, and atopy, and these ulcerative colitis, and also it can also be systemic also. Then in systemic, we have got Hashimoto's thyroiditis, pernicious anemia, and then ulcerative colitis, celiac disease, and these are the main.
Okay. Diabetes mellitus, you forgot.
Yes, diabetes.
Diabetes is the commonest, no? That is one of the
Yes.
commonest autoimmune, which is in rise nowadays. So that should be another condition which should be associated with. Then Addison's disease, then Cushing's, then all those things can be associated. So now you know that there are various investigations which can be done. And there are also various clinical signs which are present in alopecia areata. Can you name some of the clinical signs associated with alopecia areata?
So the clinical signs mainly one is the observing the exclamation mark or the
One is
tapering
exclamation
hair.
mark sign. Yes. How do you explain? How do you describe that exclamation mark?
The exclamation mark here is the like it is the tapering at the proximal end of the hair, sir, and this is because of the abrupt cessation of the hair shaft formation due to the involvement of the peribulbar area, sir.
So broad distal end and tapering proximal
Tapering
end.
proximal end.
It represents an exclamation mark sign. Then any other sign is there?
Other than that, we have got, sir, black dots or cadaver hair, sir, and
No,
then
that is all dermoscopic findings. You tell
then
clinical signs first.
cordability signs, sir.
Yes.
In
Otherwise known as, what is the other name for that? What is the other name for sign of codability?
uh,
It is described based on the person who described it. Sister
sign is in DLE will describe.
Yes, that is called a sign of codability. So if it will result in kinking of hair.
Kinking of hair at acute angle at 5 to 10 mm above the scalps.
Okay. So if you want to do a non-invasive investigation and confirm your diagnosis, which investigation do you prefer?
So non-invasive will prefer dermoscopy.
Yes. So what are the dermoscopic findings in alopecia areata?
So the dermoscopic findings, one is as already exclamation mark hairs. Other than exclamation mark hair, black dots are cadaver hairs, and then we have got broken
What is
hairs.
that cadaver hair?
These are the like leftover hair of the which are broken.
Which wellness like?
Okay.
Short.
Get into management. Let's get into management.
Other than
Management, how do you manage, Richa?
Sir, management mainly we have got initially the general measures and the topical treatment and systemic treatments. Initially the general measures, we most of the cases has less than 50% involvement. They show spontaneous
Is it also based on age? Is it also based on age? Like you would also consider age into consideration?
Yes, we can also take age. In pediatric cases, we can treat differently because to prevent any complications.
What you would like to avoid in pediatric age group, which you want to do it in adults?
Sir, systemic corticosteroids and
systemic corticosteroids are not contraindicated.
Other than that, biologics like
intralesional injections. Intralesional injection should be preferably avoided in pediatric age group. Okay, intralesional injections when it is patchy should be avoided.
Then,
okay, go ahead.
Then so after general measures, sir, initially the topicals. In topical corticosteroids, sir. And mostly in adults, we'll give topical superpotent.
Which type of topical corticosteroids you would like to use?
We'll use the superpotent types, like clobetasol propionate.
What precautions would you advise to the patient when you are using that?
Sir, we'll advise like Daily, like 2 times application, and you should be
How long?
like maximum of around like 2 weeks, 3 weeks should be used, sir.
Two
And
weeks.
then other, like
Maximum of around 2 weeks.
then sir, if there is
What will happen
any,
afterwards?
if there is any like rest, like to prevent the
Can you
tachyphylaxis,
classify the drugs used in alopecia areata?
sir.
Can you classify the drugs used in alopecia areata?
Sir, drugs, other drugs which can be like systemic drugs.
No, like for example, non-specific irritants like tincture iodine, that is non-specific irritant. Like that, biological modified modifiers like minoxidil, like that.
Yes, other than that, we can use topical corticosteroids, topical then calcineurin inhibitors, minoxidil, and then anthralin can be used. Topical sensitizers like diphencypron, and then SADB and DPCP, sorry, DNCP can be used.
Which
Other than that,
which immunotherapy, which agent would you like to use?
sir, we like to use the DPCP, sir,
Right?
diphencypron.
Can you tell the mechanism of action of DPCP?
Sir, DPCP, it acts by the Happel's principle, sir, which is the antigenic competition theory, where they induce the allergic contact dermatitis on the affected skin, so that the CD4 cells get travel from the perifollicular area to the interfollicular area, and by this way, like it acts as competition, and cytokine inhibition theory is also present.
Okay, can you name some differentials for that? Differentials for alopecia areata?
Sir, differentials for alopecia areata, one is pseudopelade of Brock, sir. Then,
What is the difference? What is the difference?
sir, and mainly the difference is in alopecia areata it is acute in onset, whereas pseudopelade of Brock it is more of a chronic condition which is lasting for about 10 years like that. Sir, other than that, in pseudopelade of Brock we'll have a white or ivory colored patches are present, and then pseudopodia like
Atrophy. Don't you see atrophy?
atrophy will be there.
That is the predominant feature
Moderate
without
atrophy.
scaling. Atrophy without scaling.
Moderate atrophy will be there. So other than that,
Okay, we'll go to the next case.
If you take a biopsy from there, what will you find? What is the histological findings?
in alopecia areata, sir.
In brief, you can tell 1 or 2 sentences.
In alopecia areata, sir.
Yeah.
In alopecia areata, the main thing we'll see is the perifollicular and interfollicular lymphocytic infiltrate around the peribulbar area, which is the swarm of bee appearance.
Which resembles that of a swarm of bee appearance.
Swarm of bee appearance.
Okay. You think that now lymphohistiocytic, instead of lymphohistiocytic, plasma cells are predominant. Then what will you suspect? Histopathologist says to you that plasma cells are predominant in your in your biopsy. Where do you get plasma cells? Okay, we'll move on to the next.
Shall we go to the next case?
Yes.
These are the nail changes.
So these are the nail changes which you can see.
Pitting.
So there are
fine stippling like pits. So trichoscopic picture. Portability. Now the second spotter. This goes to again to Aditya. So yet another bar patch. Go ahead.
Sir, here I can see a solitary, well-defined atrophic patch of alopecia, sir, with the presence of a hyperpigmented border, along with the scaling at the borders can be seen. With so mostly it's a cicatricial alopecia, sir. But due to the presence of scaling and hyperpigmentation and the peripheral hyperpigmentation, my first differential is.
Now, anything else you saw? Inflamed lesions and excoriations also you were seeing. So
Yes.
that's also one of the things which help you in connection. Okay, that also helps you in the diagnosis. Okay,
Yes.
so you are also seeing excoriation marks which are present there.
Excoriation mark.
Okay,
So-
what's your diagnosis?
So based on this, my first differential is discoid lupus erythematosus, sir. Then other differential I'll keep as lichen planopilaris, sir, and other than that, lichen sclerosus also. Sir. And then
Other cicatric, other conditions which So now you would like to tell it as cicatricial alopecia.
Yes, sir.
Secondary to all these causes, probably DLE or
Lichen planopilaris.
lichen planopilaris, or it could be lichen sclerosis, or it could be morphia, or whatever it is. So you are finding that there is a cicatricial type of
Yes,
alopecia, isn't it?
yes,
So
sir.
what is cicatricial alopecia?
Sir, like along with
Is
How
it
do you
cicatricial?
classify that? How do you
so
classify cicatricial alopecia?
cicatricial alopecias, they are classified into primary and secondary, sir. In
Okay.
primary, they are classified into lymphocytic, neutrophilic, and mixed type. In lymphocytic, we have got discoid lupus erythematosus and then lichen planopilaris. In that, again, classic type, Graham-Little Picard, and then the frontal fibrosing alopecia and pseudopelade of Rock, sir, alopecia mucinosa, and then central centrifugal cicatricial alopecia, and then keratosis follicularis spinosa decalvans. And then in the neutrophilic type, folliculitis decalvans, and then the cellulitis of scalp. And in the mixed type, acne excoriae, acne necrotica, and then acne keloidosis, and then the erythropustular dermatosis. And in coming to the secondary types, we have got the traumatic, and then in traumatic, either accidental or mechanical radiation of burns or any.
Can you tell some
Uh,
example of traumatic?
Sir, traumatic mainly like a dermatitis artifact or burns or
Traction
radiation of
alopecia.
fractional
Traction
alopecia.
alopecia itself can cause sometimes both types of alopecia. Like it can result in non-scarring also and scarring also.
Correct. And then next other types like, sir, we have
It
got
is too severe. So now we made a diagnosis of lupus erythematosus. So what are the points to say that it is discard lupus erythematosus?
sir, the main points to say this, sir. One is the peripheral hyperpigmentation and the presence of
Depigmentation.
peripheral hyperpigmentation.
Yes.
Peripheral
And
hyperpigmentation.
hyperpigmentation, along with that presence of scaling, sir, which helps.
What history will help you to differentiate DLE from that of lichen planopilaris?
Sir, in lichen planopilaris, it's more of more
History.
with itching and
What
burning.
history would like to help you? History of photosensitivity. So photosensitivity is more common in DLE when compared to the lichen planopilaris, isn't it? So that
Yes.
photosensitivity helps you in differentiating this one. So now you are seeing it can be due to either of that. So either DLE or this one. So it's an inflammatory type of this one. So if you have to differentiate an inflammatory type of this one from alopecia areata, what are the points that help you in differentiating?
Sir, mainly here on histopathologically, it is in these conditions, it is mainly around the inflammatory infiltrate is on the upper two-thirds, involving the isthmus and infundibulum.
Don't go to histology, but tell about clinical findings.
Clinically, like here there will be perifollicular erythema and scaling will be there, sir.
Yes.
And then
Erythema and scaling will be there, which will be present, and the evidence of inflammation will be there,
yes,
and there will be atrophy or follicular involvement will be there, which can be present as this one.
plugging.
Okay. So, in case now, if you want to do a rapid diagnosis, like if you want to treat, it is sometimes easy to, nowadays it's easy to differentiate it lichen planopilaris from that of this one based on the dermoscopic findings. So what are the dermoscopic findings in lupus erythematosus?
Sir, the dermoscopic findings, based on if it's an early lesion, it differs, and late lesion, it differs. In an early lesion, we'll see dilated follicular openings with the keratinous plugs can be seen, sir. Whereas in case of a late lesion, they're more of large lesions and plugs, sir. Along with that, we'll have white rosettes and follicular red dots are present in an early lesion. These are absent in the late lesion, and there are thick arborizing vessels are present in the early lesion, and the thin arborizing vessels are present in the late lesion. And along with those, scaling is more prominent in an early lesion, like mostly an interfollicular scaling, and then in case of a late lesion, it is minimal, sir. Along with that, we'll also have a blue, gray dots and brown dots are also present, sir, mainly in the periphery because of the hyperpigmentation. And these are the main.
Okay. If we take a biopsy,
Yes, sir.
in that, what are the histopathological differences or what are the histopathological findings in each of them?
Sir, in case of a discoid lupus erythematosus,
Only the main stream, this one. Main.
main mainly we'll see the
In LE, what are the
dilated
features
follicular.
you see? In LE, what are the features you see?
In
Histologically.
LE, histologically we'll see sir keratinous flux, then thickening of basal membrane, basal vacuolar degeneration. Along with that, we'll also see the dermal mucin deposition and like band-like infiltrate, and also infiltrate which is in the mainly in the upper two-third region, sir, and like follicle like isthmus and infundibulum, sir. Whereas in a lichen plantar,
Of all these features which you mentioned, which is the feature which helps you in differentiating lichen planopilaris from that of LE?
dermal mucin deposition.
One is dermal mucin deposition and vascular involvement. Vascular involvement will be predominant in DLE, whereas in case of lichen planopilaris, you will not find much of vascular involvement, although there will be inflammatory infiltrate which is present similarly.
Yes.
Okay, so that appendages can also be involved in lichen planopilaris, but vascular involvement and presence of mucin helps you in this one. Can you tell a special stain which is used for staining mucin?
We'll use Jimsa and Alcian blue stain can be used.
Alcian blue and this. Okay. So what are the variants of lichen planopilaris which can present as cicatricial alopecia?
Sir, one is a classic LPP, sir. And other than that, Graham-Little Picardy syndrome, sir. And then one more is the frontal fibrosing alopecia.
Yes. So what is the difference between Graham-Little syndrome and frontal fibrosing alopecia?
Sir, in Graham-Little, it will have mainly the cicatricial alopecia of the and keratosis pilaris, and then non-cicatricial alopecia of the axillary hair and the pubic hairs. Whereas in frontal fibrosing alopecia, will have mainly it involves the frontotemporal hairlines, where up to 1 to 6 centimeters of the hairline is affected. Will have a like contrast between the chronically sun-exposed area and a shiny block can be seen, sir. And at the edge of the
more of perifollicular erythema and
at the edge we'll have perifollicular scaling and
erythema.
Erythema will be there.
Present, whereas and that is characterized with the frontal area, but this
Frontal
can
area.
be any area. Usually vertex and this is more commonly in
Yes.
LPP classically. Okay, so what is the natural
Generalized DLE. What is generalized?
Sir, generalized DLE, disseminated one, whenever the localized one crosses beyond the head and neck region, we'll say it is going into disseminated DLE.
How do you manage?
Sir, management mainly based on the whether it is a localized or extensive one. In case of a localized lesion, we can use the topical corticosteroids can be used. Sir. In a generalized lesion or extensive lesion, we'll use topical corticosteroids along with hydroxychloroquine, and along with that systemic corticosteroids can also be used. Sir. And if there is no response, we can use either other drugs like methotrexate, dapsone, cyclosporine. All this can also be used. Sir. And then. Initially, the first general measures like sunscreen protection and then sun protection, all this should be done.
What is
and
that?
Finally, sir, dose will give at a dose of 5 mg per kg per day, sir.
5 or 6?
Sir, normally it is 6.5, sir, but to prevent the retinopathy,
what precaution do you take before initiating hydroxychloroquine?
Sir, before initiating, always baseline fundoscopy should be done, sir. Okay. And also, we should also to rule out the renal efficacy also, sir. Because if it is more, we have to reduce the dose. Sir.
Dosage. Okay. So, what is the natural course of this?
Sir, the natural course of the condition is so. If it is left untreated, it may the localized one has 5% chance to go into SLE, and the disseminated one has 20% chance to go into SLE. Sir. And then
5 to 10%, then 20%, 20 to 25% in CLE. Then it can become generalized. So,
can there be a malignant change?
Yes, sir. 3 to 5% chances it can become squamous cell carcinoma.
Okay, I think with that we will close this second spotter. Now let's get into the third one. That is DLE, and then carpet taxine, and then okay. Cat tongue, have a look, appearance. and dermoscopy. So 3. There are 2 pictures here.
Yes, sir.
Okay?
Yes, sir. I will first describe the first picture. In the first image, we can see a solitary patchy loss of hair with this associated with diffuse scaling all over the scalp, with areas of where there are multiple broken hair, which is seen along the patch. So my first, my diagnosis is black dot tinea capitis, or it can even be even a gray patch tinea.
No, it should be one of the types. You cannot tell it can be that, this, like that. What is the type in that?
Black dot tinea capitis because of broken hair.
No, you are
And
seeing
we can
more
see
of,
two black.
you are seeing more of gray scales over that, isn't it?
Yes.
You are seeing more of gray scales and not much of black dots are seen in that. If you are seeing that closely, you are seeing that there are more of patchy scales which is present with broken hairs which is present over that, and that is more suggestive of gray patch type of this one, tinea capitis.
Yes.
Okay. So your diagnosis for the first one is tinea capitis.
Tinea capitis, which is a gray patch.
Next one.
Other one, we can see a solitary, boggy, indurated, crusted plot, which is predominantly.
Induration, how can I make out on inspection?
I- It's
Can
a
I make out
boggy.
induration?
You don't touch, right? Okay.
Also,
Joint inflammation is there.
inflammatory type, which is, there is a crusted plot, which is seen over the occipital region of the scalp.
Okay, rested.
So
So
what are all the conditions you think?
My diagnosis is first Kirion, sir.
Kirion. So why you thought that it is Kirion?
Because of the inflammatory type and associated crusting we can see, sir.
One is the
And
age of the
even
patient.
the
Age of the
child
patient. Age of the patient. Age of the
age of
patient. It's saying child, isn't it? One is
yes,
age of the patient. Then second one is there's a boggy swelling which is inflamed. Boggy swelling with loss of air which is present. So that is again suggestive of that it is Kirion. More likely to be Kirion. Inflamed type of tinea capitis. Okay. So now you told that it is tinea capitis for both, isn't it? So
yes,
what are the etiological agents which are responsible for tinea capitis?
sir. Based on the mainly they are divided, the agents which are causing tinea capitis, they are divided into ectotrichs or endothrix. So in the ectotrichs again, we have the ones which are causing fluorescence and which are non-fluorescent. In the fluorescent causing organism, mainly the microsporum species are involved, where microsporum odoni or microsporum gypsum or ferruginum and even distortum. And in the non-fluorescent type,
How does it fluoresce? What is the
they
color?
give green color fluorescence on wood lamp.
If there is blue color, then what will you think?
We can think of trichophyton Charlene, which is the only species which is causing in
And also
trichophyton.
some detergents can also throw blue light. So you should correlate it with in correlation with your clinical findings also.
Yes.
Okay.
Another non-fluorescent type of ectotrichs, which mainly includes the trichophyton violation or trichophyton mandographites. Even rarely trichophyton rubrum also can cause. And in the endothrix causing organisms are mainly the trichophyton tonsurens and trichophyton violation.
Yes. What are the clinical types of tinea capitis?
Clinical types are basically divided into non-inflammatory and inflammatory type. In the non-inflammatory, we have the gray patch and we have the black dot, and the inflammatory, we have Kirion and flavus. So mainly the gray patch.
Is there something like diffuse seborrheic type of tinea capitis?
Yes, sir.
Right.
That can even present like the flavus variant, also, which presents as pityriasis cementecia with diffuse seborrheic dermatitis like scaling can be seen.
You should have a clinical suspicion before you can think of that. So how do you clinically think of tinea capitis as your diagnosis? What are the points which favor?
Clinically based on the symptomology, where if there is presence of itching
It's
and
this
along with
age of the patient.
age of the
Nowadays,
Age.
age doesn't matter, but still, age of the patient, it's more common in younger individuals. But
age
nowadays, I think we have seen so many cases of adults also having this tinea capitis and other things because of changed epidemiology. Okay.
along with that presence of itching and scaling, and along with that loss of hair and even any if there is any associated any poor hygiene or any epidemics which are involved, and in family members suffering from similar disease.
No, if you pull that air, then what will it will be lose the adherent. So easy pluckability of air without any much pressure. That is also another sign which suggests that it could be tinea capitis. Presence of scaling, presence of patches, itching, as you told, and easy pluckability of air and broken hairs. So they suggest that it could be tinea capitis, isn't it?
Yes.
So you told that there are inflammatory type. There is an inflammatory type of tinea capitis, isn't it? So
Yes.
what clinical variants of inflammatory tinea capitis?
Two types, which are Kerion and flavus. The
Kerion
Kerion,
flavus, and
yes.
sometimes it can present as augmenate pustula type also. Just it can present like pustules, but on investigations you may find that it is associated with this one. Associated with fungus. So that also you can think of. So augmenate pustula type is another type of tinea capitis which can present as inflammatory variant.
Yes.
So you told that
Almost
it is
looks like folliculitis decalvans. We get mixed, differential diagnosis at that stage. We may have to think of folliculitis decalvans also.
okay.
So of course,
You told that it is Kerion, isn't it?
Yes.
So how do you manage that? That means how do you investigate it? How do you treat that?
Treat. In the investigation, initially we can take either from the hair, which it can be plugged, where it can be given for KOH or even gram stain, and it can even wood slam.
For KOH, would you like to take? For KOH, would you like to take only air, or you also want to
Even
include scales in that?
we can take swab from the crusted lesion or
No, scales like not in Kerion, in other condition. You would like to look for scales also, or only
yes,
air?
scales also. So if there is presence of scaling, even scales can be taken for KOH.
Okay, now you tell about Kerion.
So in that, in basically in wood slam, where we can if we can differentiate between ectothrics and endothrix based on the fluorescence, where in Kerion, where Schonlein organism, it gives a blue beam kind of fluorescence, and even on culture characteristics, also we can see mainly with trichophyton Schonlein, we can see woolly or cotton type of colonies, where microconidia as well as macroconidia also can be seen. And other, we can see the characteristic trichoscopic findings, where we can see the comma hair or corkscrew hair and Morse code hair as well as zigzag hair. Other than that, we can for the treatment, where initially, because it usually presents with the crusty boggy swelling, so first in the general measures, we have to use wet compresses, where the crusted lesions have to be clean, and next we have to even start there we can start with systemic antifungals, because the role of topical antifungals is very minimal, and mainly the drug of choice is grisofulvin, which can be given at the dose where it can be given is ultra micronized or micronized doses, where in ultra micronized we can give 10 to 15 milligrams per kg per day. So it has to be given at least for 6 to 12 weeks. Or it can be given as micronized, where it is given in 20 to 25 milligrams per kg for again 6 to 12 weeks. So even other FDA-approved drug for tinea capitis is even terbinafine, which is given more than 4 years of age. We can give based on the body weight. If it is 10 to 20, we can give around 62.5 milligrams per kg, and or if it is 20 to 40, we give 125, and more than 40, we give 250 milligrams per kg. And even recently, alternative drugs like itraconazole, even itraconazole, fluconazole, and other drugs also have been used. Along with that, topicals as adjunctives to decrease the arthroconidia which are there. so that it prevents the spread of infection to the close contacts. We can give either 2% ketoconazole shampoo or selenium sulfide or 1% cyclopyroxazolamine. All these topicals also can be used. Which
Do you give
Any other
systemic
any other thing
antibiotics?
you would like to add?
sir?
Any other thing
Sorry.
you would like to add?
Actually, Kirion, we can give initially in the we can give short course of systemic corticosteroids in the first 1 week, but it is little controversial because there's a controversy. But to reduce the inflammation, we can give a short course of systemic corticosteroids for 1 week along with systemic antifungals.
Yes, you should have systemic antifungals, but along with that, you can initiate systemic steroids at a dose of around 1 milligram per kg, but in a shorter course. Then you should stop it abruptly. Okay, that can be done. If you want to give fluconazole instead of griseofulvin, then what difference does it make from other regions to that of ARI to tinea captis?
Griseofulvin, it
In a
is
dosing regimen, what is the difference between fluconazole used for other areas versus this tinea captis? Normally, you give weekly or bi-weekly dosage, isn't it?
yes, a fluconazole in weekly doses, like we can give for 8 to 12 weeks, where it is given in the dose of 8 milligrams per kg.
That's what is the difference. Like normally you give bi-weekly or weekly doses, but here you will have to initiate it daily. Daily dosage will be better instead of giving weekly or bi-weekly. So daily dosage has to be instituted
It
along.
will be given, and if it is daily, it is given as 5 milligrams per kg body weight. If it is given as weekly, then we give 8 milligrams per kg.
Yes, pulse doses it is given as 8 milligrams, and daily dosage can be 3 to 5 milligrams per kg per day.
What will be the nature of healing in both these conditions?
It will be scarring. There will be atrophic scarring, sir, with the
Where?
after the lesion gets healed. The involved area, whatever area is involved,
No.
it usually heals
In
with
which
scarring.
condition scarring you see?
Mostly with Kirion.
With Kirion, you see scarring. With black dot?
Black dot, no healing will be seen, sir, because it's non-inflammatory.
So with that, sir, we will conclude the third spotter. Let's get into the fourth one. And so this is ectotrics, endothrix, pictures, line diagrams. So spotter 4, 25-year-old male with hair loss. That's the picture.
Sir, here I can see a male patient where there is a thinning of hair involving the bilateral frontotemporal regions and even involving the vertex of the scalp. So there is no presence of any scaling, or there is no any signs of any other inflammation. So mostly my diagnosis is androgenetic alopecia in male.
Okay. What is androgenetic alopecia?
Sir, it is mainly androgen-dependent genetically mediated disorder where it predominantly it involves the hair, the dermal papilla and the hair follicles, where the circulating dihydrotestosterone predominantly acts at these levels, and it and there it even involves the even the capillaries in the dermal papillary.
DHFRS, it acts on which enzyme?
It mainly acts on the dihydrotestosterone.
No, that is correct. Dihydroepiandrosterone, that is the responsible thing. But on which enzyme does it act?
5-alpha reductase.
Type?
5-alpha reductase type 2 is most commonly involved.
Yes.
And also,
yes.
it also, and even various other reasons. There can be a loss of anchorage of the erector pili muscle, and that will disturb the stem cell niche. So that is responsible for the miniaturization of the hair follicles. And along with that, also the dermal papilla under the influence of dihydrotestosterone, it releases certain cytokines like TGF beta or interleukin 1 alpha, or all these they also result in the miniaturization of the hair follicles. And recently they have even seen that prostaglandin imbalance and involvement of pathways like Wnt pathway and peripheral inflammation, and even role of growth factors as well as extracellular even presence, I mean, vitamin D deficiencies and all, which also have been implicated in the pathogenesis.
Okay, so clinically you told that this androgenetic alopecia. Is there any way of grading it?
Yes, so there are various ways of grading in males. Like the most common, we most commonly use is the modified Norbert Hamilton's grade. Previously, when Hamilton's grade was used, and other grades are
Graded
like
from which grade to which grade?
there are 7 grades, from grade 1 to grade 7. In
Okay.
grade 1, there is only there's
Depending on the involvement, there can be various areas involved, and it can progress on. Okay. So the main hallmark you said was miniaturization air. So what is the difference between that air growth in vellus air and that of terminal air? Is there any difference in the air growth?
hair growth, like there is difference in the density. I
No,
mean,
no. In the
diameter.
length of air growth, is there any difference between a vellus air growth as well as from the terminal air growth? Why there is loss of air? That is because there is miniaturization, isn't it? It gets converted into almost similar to that of vellus air. Is there any difference in the air growth rate? So normally around
Normally, it is 2.5 2.5 centimeters per day. So. But in androgenetic alopecia, there will
per
be
day.
This can't
2.5
Per day.
per weeks,
Ah,
2.5.
ah. This is around 1/10 of that. Like vellus air growth is reduced, like nearly 1/10 of that. So that's why you will not see that it is not growing up to the mark. Okay. So when
That's why it looks
gets miniaturized, it will get this one. So now you told that males is involved. So is there any similar thing in females?
Yes, sir. In that we call it as, I mean, that pattern, female androgenic alopecia, where we classify according to the Ludwig scale, but other scales are also used, like Sinclair scale or Osland scale,
What is the
Salvin.
difference? What is the difference between Ludwig scale and Sinclair scale?
In Ludwig's, there's only 3 grades, sir, where there's grade 1 to 3, where
Sinclair
there
is
is a,
five grades.
and based on the, I mean, crown area, the whether it's parted or departed, that is on base, that is the Ludwig scale,
Okay.
1 to 3. Also.
So what are the dermoscopic findings in androgenetic alopecia?
In classically, we'll see yellow dots if it where if there are more than 4 yellow dots in the frontal region, that is a diagnostic feature. Along with that, there is a pilar sign, which includes which indicates perifollicular inflammation, and there is also more than 20% diversity in the, I mean, in the hair diameter, and along with that, there can be even a presence. So in the advanced stages, we see honeycomb-like pattern.
Can there be associated scaling? Associated scaling, seborrhea.
Associated
Seborrhea
it can
can be.
manifest. It can. There can be some coexistence where we cannot sometimes differentiate it clinically. Also, we cannot
Associated seborrheic dermatitis can be present as one of the
present
features.
as.
Okay. So when do you like to, if a patterned, this is called as patterned alopecia, isn't it? So
Yes.
in this patterned alopecia, when you would like to investigate in a patient,
If
either a male or female, when you would like to investigate?
first of all, if there is rapid progression in the androgenic alopecia, or if there is even acute onset, so if there is a rapid progression of androgenic alopecia, it indicates underlying any cardiac involvement, like coronary artery disease. And if there is early onset of androgenic alopecia, it is a marker of insulin resistance. So at that stage, we can do. And in
Any other
females,
signs? Any other things which are suggestive that investigation should be done?
yes, sir. Even in females, if we have looked for any signs of hyperandrogenism, then also we have to.
When there is associated hyperandrogenism signs, then also you should do investigations like hormonal investigation should be done in ratio to that of vellus hair ratio or this one.
That is in androgenic alopecia, it is 3:1, sir.
No,
Normally,
in AGA it is 3:1. In normal,
it is 7:1.
yes, normal it is 7:1, and it gets reduced to 3:1. So that
3:1.
indicates that again it is more suggestive of androgenetic alopecia, and associated with that there can be other findings like
Associate other find. I mean, clinically, sir. So,
no, histologically.
Histological, they can be even perifollicular, lymphocytic infiltrate can also be
Yes.
seen.
Sometimes
Or also
yeah.
peripilar cast.
Yes. They can also be associated as findings, and they are suggestive of androgenetic alopecia. Can you name some associations of androgenetic alopecia?
Associated with hyperthyroidism or hypothyroidism with diabetes and in females we have to see for any metabolic other metabolic syndromes and PCOS. They have to be.
Metabolic syndrome is one of the reported associations with this one. So you heard of metabolic syndrome as associated with many dermatological conditions, and one of them is androgenetic alopecia. So in case of androgenetic alopecia, you will have to investigate further for metabolic syndrome also. So how would you like to treat this patient?
Sir, this patient he comes under Norbert Hamilton grade 5 or 6. So first in the first line, I would like to start with topical minoxidil along with finasteride 1 milligrams per kg, and
Percentage?
I'll be minoxidil 5% with finasteride 1 milligrams per kg.
Okay. When you are starting finasteride, what are the warnings you are going to give to the patient?
One is about the, loss of libido or erectile dysfunction and all. And also baseline, I'll be first, if the patient is more than 40 years, I will even look for PSA because PSA, finasteride usually masks the elevated levels of the PSA. So baseline, I'll be doing that and I will counsel him about the loss of libido and other erectile dysfunctions and all.
So baseline PSA should be done for every patient whom you are going to start on the patient with finasteride. So after a few months or this one patient comes back to you that finasteride is not working, then what alternative options you have? Along with topical minoxidil.
Other topical agents can be tried. So
if finasteride is not working, then what is your go?
Dutasteride. Now dutasteride is, in few studies it is seen as
that doesn't cross react. You should use dutasteride instead of finasteride. You can try that because that may be helpful, although it is belonging to similar this one. So dutasteride can be started along with this and can be used. So you're telling about other topicals. What are the recent topicals under investigation?
The recent topicals are topical melatonin 0.1% and topical caffeine and topical cetirizine. And,
any estrogen derivatives are used topically? Estrogen or progesterone derivatives?
Topical lantanoprost and bimatoprost also have been.
No, that is prostaglandin analogs. I am asking you about estrogen topicals and progesterone topicals. Have you heard of alpha tridor? Alpha tridiol. So that is one which is used as topical, but results are yet to be arrived. And another one is fluridil. So that is also tried, but the results are not yet known. So those things can be used topically also, which can be, which may be useful. If it is useful, it's good.
Yes.
Okay. So.
Systemic.
Then another point is there.
Systemic minoxidil.
Yes, sir. Systemic minoxidil also been used, sir. In males, it is started at the dose of 2.5 milligrams to 5 milligrams per day. But in females, we are starting at 0.25 to 2.5 milligrams per kg. Okay. But there can be associated systemic effects can be there where there can be generalized hypertrichosis, but even other side effects there can be postural hypertension, dizziness, and pedal edema, and there can be even EKG abnormalities, and there can be tachycardia and all. But if we are using at a higher dose, if it is more than 10, then there are even chances of pulmonary hypertension and even pleural effusion.
Other methods of treatment?
Other systemic modalities anti-androgen drug, if it is in a female, anti-androgen
females it can be used.
Spironolactone or cyprotenol.
Have you heard of PRP?
Yes, sir.
PRP, what is its role in androgenetic alopecia?
That mainly it prolongs the anagen phase and it improves the actually hair diameter density.
It is used as an adjuvant along with other rather than a single this one. Any other modes of therapy? Mesotherapy is also used.
Yes,
then aromatherapy is used.
Intralesional.
Yes, then GFC and dutasteride mesotherapy, and even recently even
What are
exosomes
mesotherapy?
exosomes with hematopoietic stem cells also they have been used. Along with that,
Okay.
FDA approved.
Comment. We are time is up, and then we are just comment on surgery. Where from you choose the donor site?
The donor site, it is usually around 2 centimeters above the occipital protuberance, which is in the horseshoe shape, which is around 4 to 5 mm within involving the occipital area. And mostly the patients with Hamilton grade 4 to 5 are usually taken who have good donor site and with no realistic expectations, and they have even good, healthy recipient site and no other serious systemic comorbidities or anything.
Okay. Methods of grafting and comment on merits and demerits in a couple of sentences.
We have follicular unit extraction as well as follicular unit extraction technique is there. So the merits and demerits are like if we um, if we have to counsel the patient, like if we have to see the pattern of hair loss. If the androgenic alopecia is not stable and we are doing the hair transplant, there are chances of there are high chances of failure. Along with that, if there is diffused unpatterned alopecia area, androgenic alopecia which is predominantly involving the hospital area also, then there are chances of failure of the hair transplant. So the
Okay, that's
patient
fine, Priya. That's fine, Priya. Now, what's his name? Sanket. Sanket will take a couple of pages. So that's about protein, androgenic alopecia. So spotter 5 for Sanket. Sanket, 35-year-old female with hair loss.
So here we are seeing a clinical picture in which there is a diffuse staining of hair in the biparietal region, and on the right side it is showing there is strands of huge strands of hair can be seen. So my differential diagnosis are, and on the extreme right, on the microscopy we can see it's club-shaped ending of the hair strand, which is suggestive of the telogen hair. So my first differential diagnosis is telogen effluvium, and along with another differentials are anagen effluvium.
How do you identify telogen hair?
Telogen end is by the club-shaped end, which is seen on the microscopic picture on the extreme right, sir. The club-shaped end that is seen.
Okay. What is telogen effluvium?
So telogen effluvium is defined as a diffuse. It is defined as a diffuse, generalized, non-scary alopecia, in which causes changes in the hair cycle uh, due to the reaction due to the reactional changes secondary to the physical and psychological factors.
Insult. Okay. So how do you classify telogen effluvium?
Telogen effluvium is classified. They are basically the three bases of classification. One is on the basis of duration, one is on the basis of the changes in the hair follicular cycle, and one is on the basis of that etopathological changes. First is on the basis of duration. One is acute and chronic. The acute telogen effluvium is the one which occurs within 2 to 3 months of any precipitating factors, and the chronic ones are the one which occurs like over the prolonged duration for the 6 months. And then comes the on the basis of the changes in the follicular cycle, that is the Headington's classification. So Headington's classification is divided has further 5 types: early anagen release, late anagen release, early telogen release, late telogen release, and the short anagen phase. So in early anagen release, the anagen hair, like there will be premature shortage of shifting of anagen to telogen phase, most commonly seen following any drugs or any cytotoxic drugs or any acute conditions like fever or surgery. That is the early anagen release. Then coming to the delayed anagen release. In the delayed anagen release, the anagen duration will be for the prolonged time. Then when the anagen gets converted into the anagen phase that gets converted into the telogen phase, there will be sudden.
Can you name some conditions with acute telogen effluvium?
The conditions with acute telogen effluvium are as follows. One is the starting from crash dieting, anemia,
then certain conditions like any
Anemia will not be sudden onset, no?
fevers, especially COVID infections, or certain drugs such as homeopathic or homeopathic drugs or Unani medications can also cause.
Okay. So you told that it is anemia. Anemia comes under which classification?
Anemia comes under the chronic classification, chronic telogen effluvium.
Chronic air loss with telogen airs. So
Chronic
there is another intermediate
known to cause telogen effluvium, and hypothyroidism is also known to cause.
malignancies,
And the certain malignancies also.
malignancies, syphilis, then HIV. They can all
HIV,
result in chronic telogen effluvium. Or
chronic telogen effluvium.
okay. So what will telogen effluvium? Is a diagnosis of exclusion. So
So
after
that's
excluding all the causes, you should make a diagnosis of telogen effluvium. So what are the dermoscopic findings with which you can suspect telogen effluvium?
so in telogen effluvium, first and foremost is there will be growth of single follicular units, and secondly there will be less than 20 centimeter variation in the hair diameter, and apart from that there will be yellow dots. Absence of there will be yellow dots will be seen, and absence of hair follicle growths will be seen.
Absence of
And empty hair follicles will be seen. Empty hair follicles will be seen.
empty hair follicles. Okay, without any this. What are the differentials?
So for telogen effluvium, another differentials are anagen effluvium also, and female pattern hair loss can also be another differential.
Okay. What investigations would you like to do in the case of telogen effluvium?
So telogen effluvium, one is on the basis of first we'll do a extensive questioning and during history taking in order to rule out what are the various causes, and on the basis of that we'll ask for CBC and serum iron, serum ferritin levels, and thyroid function tests, and
ZVDRL
and serum vitamin D3 levels also.
ZVDRL
And VDRL also, like if it is if you are suspecting syphilis, then also we
What
can.
is gravidarum?
Pardon, sir?
So what is
The
Sabrot's
commonest
maneuver?
probably.
What is Sabrot's maneuver? What is Sabrot's maneuver? Sabrot's maneuver. Heard of it?
No, sir.
It's also called as air pull test.
It's hair pull test is also known as Sabrot's.
So that is air pull test. What is it air pull test?
So in hair pull test, there are two types of hair pull test. One is the standard hair pull test, and one is the author's modified hair pull test. So in the standard normal hair pull test, we with the help of index finger and the thumb, we will pinch grasp approximately 40 to 60 hairs as close as possible to the scalp, and then we'll pluck it. If the grasped hairs are more than the 10% of the one,
okay. What is the difference between air pull test and trichogram?
So in for trichogram, we will basically that's one by one, like in the 1 millimeter square area.
You will take one by one. Okay.
1 millimeter square area, the hair will be cut, and then the hair growth will be monitored at baseline.
In case of air pull test, you have to do it gently, but this is done forcibly with a clipper. These clippers will be used, and then it can be pulled forcibly. In this case of trichogram, it should be done. Okay. What are the differentials you told? How do you differentiate telogen effluvium from early onset female pattern alopecia?
So in
Lineage, right? You don't see it.
How do you differentiate?
Lineage, right?
dermoscopically we can see, sir.
Yeah, that is one.
And then apart from that, the hair pull test can also.
What is Christmas tree pattern? What is Christmas tree pattern?
Yeah.
Christmas tree pattern. Okay, how do you manage this case of telogen effluvium?
So first is on the basis of first we'll rule out the underlying what are the underlying causes for the telogen effluvium. So
You have
one,
concluded now that it is telogen effluvium. So how do you manage it?
say if the patient is having any certain nutritional deficiencies, we will correct those. Such as if the patient is anemic, we can give her iron supplements or we can give biotin supplements also. And apart from that, 2% of the minoxidil, 2% topical is like
Directly,
2%.
directly you straight away go to minoxidil. What is the natural history of telogen effluvium? Acute telogen effluvium, how long does it last usually? It lasts
Three,
for around 3 to 4 months usually.
3 to 4 months.
So first, initially, you should counsel the patient with regard to the self-limited nature of this before starting on this one. In case of chronic telogen effluvium, you can use minoxidil topical and along with other supplements.
So recurrent telogen effluvium, what are the causes?
Recurrent telogen effluvium, most commonly it is the
Okay, we'll get into the spotter 6, okay? That's good enough for the fifth spotter. Dermoscopic findings of telogen effluvium and spotter 6. This looks peculiar. Come on, give
So-
a narration.
So this is the clinical picture which is showing multiple discrete to coalescent flesh-colored dome-shaped papules over the dorsum of nose, extending over to the forehead and over the nasolabial folds. So my differentials are: first is the trichoepithelioma, second is syringoma, and third is the and third is the adenoma sebaceum.
First
Fourth
is
is,
Third is adenoma sebaceum, sir.
last one is,
Adenoma sebaceum. Last one is
huh?
the last one is adenoma sebaceum.
Adenoma
First one is
No,
first
first
one
one
is
is trichoepithelium. So why
first
do
is
you say, okay, what type of trichoepitheliomas it is? Solitary or,
it's basically it's a solitary trichoepithelioma, sir.
no, here, in your spotter, you are
In
seeing
this,
multiple lesions, no?
multiple
so these are
trichoepithelioma.
multiple trichoepithelioma.
So it
So
is
it
a
is
case of multiple trichoepitheliomas. So then, what are the types of trichoepitheliomas?
one is the solitary localized multiple trichoepitheliomas, desmoplastic trichoepitheliomas, then solitary giant trichoepitheliomas.
Okay. What is the difference between solitary and multiple trichoepitheliomas?
So the solitary trichoepitheliomas are basically localized over predominantly over the nasolabial folds. Whereas the generalized ones, they will be more widespread. Along with that, the widespread will have other associations such as Brooks-Pegler's
No,
syndrome,
no, no.
and then
Differences you tell that associations will come later. Is there any
generalized,
genetic difference between them? Is there any genetic difference? Which is more commonly inherited?
which is
What is the inheritance of this?
autosomal dominant.
The multiple are usually inherited.
Multiple are usually inherited, having autosomal dominant in it.
Inherit type of inheritance. Okay. So why not acne is a differential diagnosis for that? How do you differentiate acne from that of trichoepitheliomas?
What do you see in acne?
In acne, mostly comedones will be seen, and in this picture, we can't see comedones.
No, yes, comedones are not seen. That is one difference. And where will be usually acne located majority of the times?
Majority
It is
of
centrofacial, isn't it? Centrofacial location is here in this trichoepitheliomas, whereas acne will be located over the periphery.
like
So the cheek
bilateral malar aspects of the face.
and onset will be early in this, and that will be pubertal. Here also it can be pubertal, but it will be persistent. That will be appearing and disappearing. And there more of inflammation can be there. Here there is less of inflammation and it remains stationary. Okay. So now
How
we
will it differ with adenoma sebaceum? How will it differ with adenoma sebaceum, and what do you look for?
In adenoma sebaceum, it is basically an angiofibroma. In adenoma sebaceum, along with these adenoma sebaceum lesions, we'll also look for the other skin lesions confetti-like lesions, hyperpigmented ash leaf macules, and Chagrin's patch, and the periangle fibromas, also known as the angiofibromas, also known as the Conan's tumor.
Which sex gets involved more in trichoepithelium?
Female, most commonly the females. Females more than males.
Tell me one yet another condition which is flat-topped nodular lesions on the face, commonly seen in females.
Syringoma is one of the features.
From which tissue syringoma arises?
Syringoma basically arises from the acrocerium of the sweat glands.
Okay, so we are talking about Brooks syndrome, no? What is the components of Brooks syndrome?
So the Brooks-Pegler syndrome, myeloma is a benign and blastoma is more malignant.
Both are benign.
No. Blastoma is malignant, and trichoepithelioma is.
Trichoblastoma was earlier used, but nowadays it has been grouped under this one only, as trichoepithelioma itself. Earlier there were two different terminologies, but they are grouped under one now. Okay. If you take a biopsy from there, if you take a biopsy from a single lesion, then what will you find? What histological findings will be there?
So characteristically, it is characterized by horn cyst, which it is horn cyst, and which will be, and there will be palisading of the basaloid cells. Where palisading of basaloid cells will be seen along the amorphous material,
Okay.
and that is the character. That is will be the characteristic feature. And apart from that, there will the cellular atypia and mitotic activity will be less.
So that's how we can differentiate it from
BCC, basal cell carcinoma.
Okay, so what will be there in BCC?
So in basal cell carcinoma, there will be more cellular atypia and high mitotic rates. And apart from that, around the palisading cells, there will be more of a mucinous trauma and artifacts such as clefting due to the increased fibroblast activity.
Okay.
Any suggestions with respect to treatment?
Pardon, sir? Treatment.
How do you treat? Is there any treatment for this?
So treatment are various lines of treatment are there. One is the surgical excision, radiocautery, electrocautery, then lasers.
Will there be a cosmetic improvement after all those maneuvers?
There won't be any cosmetic.
Okay, let's leave this.
Recurrence is common, so there will.
Yeah. Recurrence is common. So whatever procedure you do, there can be recurrences.
There will be recurrences.
Yes. Dermabrasion can also be done.
Yeah.
As treatment modalities.
Okay, that's the end of the spotters for today. And now that is trichoepithelioma, and that is the biopsy. Now let's get into round two. Round two is the differential diagnosis. We have three set of cases. Now, the first set goes to Aditya.
Yes.
What the differences? What is this? Give a narration of both the.
Yes. Sir, so here there are two cases, sir. In the first case, the patient is a 32-year-old male, farmer by occupation with itchy, scaly red lesions and pustules and easily removable hairs. So what I can see here is the multiple erythematous pustules are seen on the beard region, altogether forming a plaque-like lesions, which are present in the first image. And now coming to the second image, we can see a 45-year-old male patient with recurrent episodes of eruptions of red raised and pus-filled discrete lesion. So here, with long term. So here I can see the multiple discrete erythematous pustules and papules are seen mainly in the beard regions. So So for the main differentials in the for the first case, I'll be keeping as mainly the either the tinea barbe or psychosis barbe, sir, in the first image. So because as the patient is having like multiple erythematous lesions, and as the history shows, pharma by occupation, and also there are easily removable hair without any pain. I think it most goes towards tinea barbe, sir, than psychosis barbe, and also acute in onset. Whereas in the second image, my differences are same, but the order may change. Like initially, it can be the bacterial folliculitis or psychosis barbe, and because I'll keep the psychosis barbe because as it is a recurrent and long-term chronic lesion, I'll be keeping it as psychosis barbe, sir, and the lesions are discrete here.
Which condition there is more inflammation?
So in the main it is highly inflammatory in case of a tinea barbe, sir, and less inflammatory in psychosis. But again, in the tinea barbe, we have got different conditions also, like the Kirion type and the psychosiform type and the non-inflammatory types are also present, sir. Out of this, the psychosiform and the Kirion type are highly inflammatory.
What are the clinical presentations? What are the clinical presentations of tinea barbe?
They are the one is the psychosiform types, which will be very similar to the psychosis barbe with multiple follicular pustules, and the second one is the Kirion type, like a boggy swelling, like present in this with studded with pustules, and the last one is a non-inflammatory type with multiple annular scaly blocks are present.
Routine type, that is normal as annular blocks, which can
annular blocks.
Really. Okay.
So that's the differential diagnosis for first one. Shall we? You want to ask some more questions, or
so what about like you? How do you differentiate psychosis barbe from that of tinea barbe?
Sir, mainly one is the tinea barbe is highly inflammatory compared to psychosis barbe, sir. And other than that, tinea barbe is less. It is mostly asymptomatic, and hair pulling is more characteristic towards the tinea barbe compared to psychosis barbe.
Easy pluckability of hair.
Easy pluckability of hair without any pain.
It's without any pain. Whereas in case of psychosis barbe, you will have follicular-oriented pustules, which do not, which are not easily pluckable, and which can be inflamed. Ultimate confirmation is by
KOH is the main, sir, because with gram stain in both of them we can get staph aureus, sir, but KOH is the main one which helps in differentiation, sir.
So how do you manage that? In case if you cannot differentiate, KOH is negative. You don't know if KOH is negative sometimes. Majority 50% of the times you won't get positive. Then how do you manage it?
Sir, initially I'll be managing using the.
You should add a course of antibiotics also.
Antibiotics.
Sometimes there can be an overlap, and then along with that add antifungal.
Antifungals also.
Systemic.
Yes.
You told that here there is in the second picture.
Yes.
So how do you differentiate psychosis barbe from pseudofolliculitis?
Sir, in case of a pseudofolliculitis, if you carefully observe, we can see the incurving hair can be seen, sir. Incurving hair helps in differentiation, sir, which is the main one. Other than that, in psychosis barbe, recurrent folliculitis is present, sir, and then
yeah, we have a picture of pseudofolliculitis. We can. So with that, we'll get into the second one. So that is the picture. Priya.
Yes, sir. Here we can see two images where initially in the first image we can see a very solitary large patchy loss of hair where there is hair at different lengths, and we can see it is present over the right side and predominantly over the right frontoparietal area, and we can see hair at different broken at different lengths. So here my diagnosis is trichotillomania. And in the second case, we can see multiple scattered patchy losses of hair, which is seen predominantly over the occipital area. So here, with the underlying description where there is a presence of other systemic complaints. So my diagnosis, I mean, there I can have different. My differential diagnosis are first the moth-eaten alopecia, under which the most common is the secondary syphilis, and even other other cause of moth eaten alopecia like alopecia areata or even systemic lupus erythematosus or even other causes of like
Lupus erythematosus.
lupus erythematosus.
Then there can be again patchy hair loss.
Patchy.
Okay, so you told trichotillomania as first one. So what are the
Yes.
points which favor trichotillomania?
One is the
What is the age
location,
group? Age group.
age most. I mean, in the females in the adolescent age, mostly.
First is in
One is
first
the
decade or first decade also.
middle-aged female.
It is bimodal. Like it can be in first decade as well as in the late
The
phase.
middle-aged female, and even we can see it is even in children. Yes,
What are
sir,
the
it can be
points
seen in
which
children.
what are the points which suggest that it is trichotillomania?
One is it is present over the right side, sir, where the dominant side and easily accessible area. And even we can see hair of different lengths, which are broken at different levels. And it's
Which
the
group of disorder does it come under?
Sir,
Do you want to examine other areas also? What are they?
yes, sir, we can even look for other accessible areas like if there are any eyebrows or even
Eyelashes.
eyelashes.
Yes.
Here
So
we
it's
can
an
see.
anti disorder. How do you manage it?
So mainly behavioral therapy and even tricyclic antidepressants like clomipramine and serotonin reuptake inhibitors like fluoxetine, and even N-acetylcysteine, the glutamate, and even recently memetin, that is also glutamate inhibitor. All these have
Which
been
was the drug of choice earlier?
I mean the serotonin reuptake inhibitors.
Which one?
Fluoxetine.
No, that is used nowadays. Fluoxetine is used
The
nowadays. Fluoxetine, then mirtazapine, then there are various other drugs which are used recently.
doxepin.
Pienzapine. A word of pimosid.
Yes.
Is it used nowadays?
Now it's not used.
Why?
I mean, it is causing QT prolongation.
Cardiovascular side.
Cardiovascular.
It's not used because of its cardiovascular side effects. So you should counsel the patient as well as treat the patient psychologically also.
Yes.
In this,
So
what
tell me,
investigations would you like to do? In the second one?
The second one, first, if the primary cause, like if the most common is the secondary syphilis, so I'll be doing the VDRL and VDRL along with typers and to confirm with TPH and TPH and other investigations like CBC and all. If I want to rule out
Blood VDRL is reactive at 1:4. Which other test would you like to do to rule out that other condition?
TPH,
TPH is. Then you thought of SLE also as another condition. So there also blood VDRL can be biologically false
false
positive.
positives can occur.
So you should also look for other things and then look for ANA also feasible. Okay. So if it is secondary syphilis, then what will you treat?
The main treatment is injection benzathine penicillin, which is injection benzathine penicillin gene is given as 2.4 mega units, half dose in each butter.
Okay, it responds very well.
Response.
If it is HIV positive patient,
Then antiretroviral, the same therapy can be given.
same dosage can be used. We'll go for that.
Yeah. Okay, Priya, now, no, not Sanket. Now it is your turn. There are two pictures. Have a look and start talking. Hair shaft abnormalities.
So here here we are seeing the microscopic pictures of the hair strands. Case one is on the extreme left. It is showing there is a defect in the cortex and there is splaying. There will be splaying of the hair cortex. There will be break in the cuticle and there is a splaying of the hair cortical cortex, and it is characteristically showing plain brush-like appearance. So it is most likely suggestive of trichorexis nodosa, whereas the picture on the right side, it is showing the invagination of the proximal part of the hair shaft into the distal ones. So hence, and producing a characteristic nodular lesion, that is the trichorex. So this is suggestive of trichorexis invaginata, and the down picture, clinical picture below, it shows the arcuate or the circinate scaling, circinate hyperkeratotic plaques with characteristic double-edged scaling on the close observation. So the case 1 is suggestive of trichorexis nodosa, and case 2 with correlating with the clinical picture, it's the first one, the top one is the trichorexis invaginata, and with the double-edged scaling, it is suggestive of the Netherton syndrome.
So
What is the
scale
inheritance of
appearance.
case of trichorexis nodosa?
It's autosomal dominant.
And invaginata?
Invaginata is autosomal recessive.
That's all. So, what is this particular picture called? Case 1.
Pardon, sir? Which picture, sir? Left one? Left one or right?
Two brush shape.
What are the causes for trichorexis nodosa?
The causes of trichorexis the nodosa, it is basically having various associations, such as many case kinky hair syndrome, also with Netherton syndrome, and it is also associated with argianosuccinic aciduria, and which is due to deficiency in argianosuccinic lyase, citrullinemia, Laron syndrome, ectodermal dysplasia, and these are the few causes.
Okay, so it's
So
these
many
both the
cases.
conditions are common for which condition? Both the conditions, both the type of hair shaft defects can be seen in which condition?
Netherton syndrome, it can be seen.
Okay, what is the associated event for Netherton syndrome?
Netherton triad.
How does it
So,
present?
the Netherton syndrome, it will be characterized by ichthyosis linearis circumflexa, trichorexis invaginata, and along with that, patient will have atopic dermatitis and serum raised IgE levels.
Okay, what is argianosuccinic aciduria?
Argianosuccinic aciduria is basically genetic. It's basically due to the urea cycle defect, due to the deficiency of argianosuccinic lyase. So there will be increased accumulation of the argianosuccinic acid, and that will cause other extracutaneous
CNS
there will be
defects and
CNS manifestations like mental retardation will be most commonly seen, and failure to thrive.
Okay. So, shall we go into the rapid fire? Now, rapid fire. There are 10 spotters here, 10 pictures, and for every picture, diagnosis, and then why you diagnosed, and a couple of questions will be there. So, Mutiga, let us start.
yes. So can you spot this?
Yes, sir, here I can see a large atrophic patch of alopecia, sir, with white lesions in the center. So it's looking like a cicatricial alopecia, sir. Based on as there is no major inflammation and scaling, my differential here is the pseudopelade of Brock, sir.
Yes. So pseudopelade of Brock, it's an end stage of several diseases, isn't it?
Yes, sir.
So
And
if it is in early phase, what are the treatment modalities you can do? Medical line of treatment.
So medical line in the initial phase to stop the inflammation is the major one, sir. So we can use either topical corticosteroids or any systemic agents like methotrexate, cyclosporin, all can be used, sir.
Why not systemic steroids?
Systemic steroids also can be used.
Okay, what is the second line? If it is not
Intralesional steroid.
Intralesion also, sir, but the response is poor in case of pseudopelade Brock's.
so how do you manage if it is not responding to medical line of treatment?
If it is not responding to medical line, if it goes into burnt out stage, we can treat with surgical modalities, sir, like either a hair transplantation or other scalp reduction, sir.
Grafting would be better. Medical line of treatment should be tried before you go for surgical line of treatment, because
Yes.
sometimes it may respond, but it will take longer time.
Yes.
Okay.
Apart
Next
from
one.
systemic steroids, you can also use hydroxychloroquine in combination with Dapsone. That is also second line, which is helpful sometimes.
That's great. Okay. Second one. Is this? Sorry.
Sir, here you can see a female patient with hypertrichosis on the face, sir. Other than that, and reddish fluorescence in the urine container. So mostly a porphyrin disorder. So as there is only urine involvement and hypertrichosis, mostly going towards a porphyria cutaneous tarda, sir. And
What are the cutaneous features associated with porphyria cutanea tarda?
so
What is the
main.
age of onset? Age of onset.
Sir, there are two types of major, three types are there, sir. The type 1 is the sporadic one, which occurs in the adult age group, whereas the type 2 is the inherited one, which is seen in children, sir. Like based on this, the age of onset will change, sir. And the cutaneous features are mainly the following the sun exposure, there will be photosensitivity, then the skin fragility, erosions, and like bulla and erosions, and poor wound healing. Then later it can go into sclerodermatitis changes, and then dystrophic calcification can be there, and monkey-like faces due to hypertrichosis can be there.
How do you confirm your diagnosis?
Sir, will confirm the diagnosis by the one is the checking for the porphyrin levels, sir. So one is the urine porphyrin level and the RBC, plasma, and feces, sir. Out of all this, in case of porphyria cutanea tarda, RBC porphyrin levels are normal, whereas other three, the serum, urine, and feces are showing increased porphyrin levels, and characteristically the urine shows red fluorescence.
Okay. Next one. So we were discussing this. You were mentioning Dr. Murthy. So the diagnosis, Aditya, you take this.
Yes.
And also the next one. You will have 4.
Sir, here I can see a male patient with the terminal hair in the beard with multiple inflammatory papules and pustules are seen on the beard region. Sir, on close examination, I can see the ingrown hair coming out, sir, which is pillae incarnati, which is characteristically found in pseudofolliculitis. Sir. And,
Otherwise called
uh, pillae incarnati, sir.
yeah,
Pseudofolliculitis barbae.
or razor bumps.
Razor.
So what is the cause? Etiology?
So the main etiology is one is it is racial, sir. One is Africans are incurving hair, and one more is the reverse shaving, which is called. And
Pathogenesis, how it occurs?
sir, one we have two types, sir. One is
So
the
tell in
hair which
two words you can tell.
like foreign body granuloma.
Yes,
Like
it induces foreign body granuloma.
foreign
Okay.
body granuloma. And
So how do you differentiate it from psychosis barbae?
sir, yeah, like based on history, it is seen immediately after shaving or is seen, sir. And other than that,
The
recurrent.
psychosis barbae is seen when air is left. This is seen when air is shaved. So that will result in because of reverse shaving. So that is one difference. And another thing is here there will not be follicular oriented. It will be just perifollicular.
Yeah,
In that
follicular
process.
involvement.
And there it will be follicular oriented.
How
And
do you
ultimate
treat?
diagnosis is by gram staining.
How do you treat?
So management is one of the general measures helping in better practices of shaving and trimming other than shaving, and other than that topical antibiotics with corticosteroid uses.
So either grow it or trim it close, right? Okay. Next.
Sir,
You will take this, Aditya.
sir, here I can see a newborn child with a scalp defect, sir, without any skin or subcutaneous tissue. I can see. So the major differential when at birth without any scalp defect is a aplasia cutis, sir. So my difference is aplasia cutis congenita, aplasia cutis congenita.
Aplasia cutis
Other than,
congenita.
other than,
How do you
other
manage?
than
What is the natural course of the disease and how do you manage?
So normally, most of the cases at birth will not have any defect. They will have only a atrophic patch of ball patch will be there, sir. But for a few cases, there will be defect of skin and subcutaneous tissue can also be there after birth, sir, which slowly heals on its own, leaving atrophic ball patch on the scalps.
So here there is a question. What is the inheritance?
Inheritance is autosomal dominant inheritance, sir.
If there is presence of bullae or lower limbs associated with this, then what it is called as?
Dystrophic epidermolysis bullosa, we should think. Epidermolysis bullosa.
It is called as what syndrome? Huh?
Kindler,
Not Kindler's. Very Kindler is different.
Adams.
Bart syndrome. Bart syndrome associated with dystrophic epidermolysis bullosa. What is the other name for that aplasia cutis congenita? Congenital absence of skin. So there are different types in that. This is one of the types.
Okay. Okay, Priya.
Yes.
Oh,
Here,
your spotter is very beautiful, and then you are lucky to get this spotter. What is this onto your left? Is there any dermatological entity on her?
yes, sir. There is madarosis. There,
People
superciliary,
crave to have a glimpse at this picture.
there is superciliary madarosis, sir.
Superciliary madarosis. So on right side. So what are the different causes of madarosis?
One is infective causes where mostly with leprosy or even in HIV and even other autoimmune disorders like atopic dermatitis and even in case of eczemas and other causes where there's alopecia mucinosa and endocrine causes, or in even in case of DLE and distal lupus erythematosus, or in any like any therapy with the chemotherapeutic drugs or chemotherapy and radiotherapy.
Myxedema?
Even in myxedema, papillosquamous disorders like psoriasis and ectodermal dysplasias and all.
Okay. What is the sign when it is associated with atopic dermatitis called as? Is this condition called as when it is associated with atopic dermatitis? Altoxin. Altoxin. It's called as. And as you told, there are several causes for that, and you can differentiate based on other clinical findings also.
Yes.
Okay. Next one. What is this?
Here we can see there is enlarged, this is ciliary trichomegaly, sir, where we can see enlarged follicles of the eyelashes. It is associated. It can be associated with various drug therapies, either with most commonly with zidovudine or even other drugs like even minoxidil and cyclosporin and dipencilamine and phenytoin and even heavy metals and lantanoprost, which is initially used for glaucoma. Even that resulted in ciliary trichomegaly.
Okay. So this is a.
So it's one of the indicators of HIV. So trichomegaly is one of the rare disorders which is seen more commonly associated with other rare conditions like loss of hair, sudden loss of hair and other things. You should keep in mind whenever you see trichomegaly to investigate into the cause.
Yes.
What is this?
Here in this image, we can see a child who's having sparse hair, which is brittle and all. And also here in the microscopy, we can see twisted hair, which is pili torti. And the most common diagnosis is Menke Kinki's hair, and the gene defect is mainly ATP7A gene, which is involved. So there is in this there will be defective copper metabolism, defective copper transport. So there will be other associated features like involvement CNS abnormalities and all, and even bone growth. Bone defects and decreased growth and even renal failure.
What else you are observing in that patient? Along with hair loss.
Other than the hair loss, we can see protein energy malnutrition. Like,
See that the baby is apathic, like it is cryful. It's not active. It's looking like dull, and it is
Lethargy.
it's appearing as if it is crying.
Yes.
So neurological involvement is also commonly associated with this condition. So usually, which sex is more commonly affected? What is the mode of inheritance?
Males are X-linked recessive.
Okay, which sex is more commonly affected?
Males are more commonly affected.
Who manifest commonly?
Females mostly manifest.
Because it's lethal for males when it is X-linked recessive. So usually they do not live longer. So it's usually female children who present to us with these conditions. And how do you confirm your diagnosis?
Based on serum, the celloplasmin levels. A pop. Serum celloplasmin levels.
Yeah, and also air shaft, this one you can see. You can also confirm it by that pilot artery, that is 180-degree twisting will be there. So that also suggests that it could be in the clinical part, in the cooperation with clinical finding.
Yes.
Okay. The eighth one, Sanket, you will take it.
Yes.
What is this?
So this is a clinical picture which is showing alternating light and dark bands over the strands of hair. So it's a suggestive. It's showing a characteristic feature which is known as the flag sign, and it is most commonly seen in protein energy malnutrition such as kwashiorkor. And apart from that, it is also seen in other causes include mostly the drugs such as intravenous methotrexate in children and other cytotoxic drugs such as cisplatin, carboplatin, doxorubicin. These are also known to cause flag hair.
Good. So that is flag sign for you. And the next one is, what is this? This is a rare entity, and then what is this?
So this clinical picture is showing there are multiple discrete follicular hyperpigmented follicular papules or the dorsum of nose. So and on the close examination of the right picture is showing hyperpigmented papular lesions. So some broken hairs can also be appreciated, sir. Very small. So this is suggested for. So the difference, it is mostly trichostasis spinulosa.
What are the differentials?
So another differential includes the open comedones, keratosis pilaris. Also, it's
any vitamin deficiencies can cause similar condition.
Trianoderma can also cause.
Which one?
Trianoderma. Essential fatty acid deficiency.
That don't present over that. No, Trianoderma, does it commonly present over that area?
No, it's not. It most commonly.
Which condition presents over nose? I've heard of nasolabial dysabasia. Nasolabial dysabasia.
I don't know. Sorry.
So that is associated with vitamin B complex deficiency. So there also it can be keratinized lesions can be present. and treatment with that will along with calprolitics will improve. Whereas for this condition, you have to do a
Laser hair
biopsy and
removal.
intervention.
Laser hair removal is also included.
Okay, so this is a rare condition, and then we are coming to now the next one is the last one.
So the clinical presentation, firstly on the left side, it is showing a patch of solitary patch of alopecia with the follicular papules when suppurations with crusting, and central patch of and peripheral erythema and central patch of alopecia is seen. And then on the extreme right, on the further magnified image, there are multiple follicles like hair follicles are arising from the acrotracheum. So this is clinical picture is suggestive of folliculitis decalvans, different type of folliculitis decalvans. And my closest differential for folliculitis decalvans is dissecting cellulitis of the scalp.
Okay, folliculitis decalvans, rare entity, but we should keep in mind always when we are making this diagnosis, we should
And along with that, the carrion is also the difference.
we should exclude tinea capitis,
Tinea
carrion,
capitis.
or we make the
Carrion.
diagnosis of folliculitis decalvans.
Decalvans.
Otherwise, we'll be doing great injustice to our patient because it can lead to gross scar formation. So, Murtigaru, with this, we are coming to an end, and you also look tired, but because of your extraordinary performance, thank you very much for accepting our invitation and
Thank you, sir.
playing very active role, and we all enjoyed. Really, we all enjoyed your presence on the screen, and then I was always canvassing for you, and then I'm sure my people around in my department they endorse that my choice is good.
Thank you, sir. Thank you very much for your invitation as well as taking me as a part of this. And I am thankful to IADWL AP also for having invited me and given me an opportunity to participate in this. Thank you all.
There are a couple of
Best wishes to all
audience
the
questions.
students. Best
Yeah.
wishes to all the students for your exams.
Okay.
Thank you, sir.
Thank you.
So there are a couple of audience questions which Dr. Farzana will be reading. Okay.
So we don't have many questions. I think only a couple.
Good evening, madam. So, any treatment for 20 nail dystrophy? One of the audience asked, but I think it is not related to today's topic. Hair disorders. If
We-
anyone can take.
Yeah, we try out usually with vitamin E derivatives and sometimes topical retinoids and sometimes even pulse therapy also, depending on the cause. But
Yes.
the therapy is not very effective as.
Yes, sir. And another question was enlightened systemic minoxidil and alopecia. It was covered during discussion, I think, madam. So, shall we conclude, sir?
Yeah. So
Thank you very much.
So let us conclude, and then thank organizers, our president, Dr. Kavita, and then organizing secretary, our Saujanya, for giving our department this particular opportunity. And I thank all the postgraduates who really performed very well. So thanks a lot.
Thank you, sir.
Thank you very much.
Thank you, both of you, sir. Thanks for accepting our invitation. And we have utilized the full 2 hours today. The cases and all were very good, and the discussion was, I think it's very beneficial to all the postgraduates throughout AP. Thank you, sir. I thank our president, Dr. Kavita. This is her idea. Dr. Sitaram sir and Dr. Kavita came up with this idea of PG clinics.
First,
Very
you give me an opportunity to thank Dr. Sitaram because for his vision and then designing this particular program, extremely fruitful to postgraduate students and very good. We really enjoyed and we have been enjoying. Dr. Sitaram, thank you very much and for making us a part of this. Thank you.
Thank you, sir. I thank Sir, would you like to say a few words, sir?
I think today's program is very excellent, sir. Ramchandra sir and Murthy sir have taken us through the entire gamut of the hair disorders. Almost, I think it is a refreshing for every one of us, and including the postgraduates. It's a very nice discussion, excellent discussion with very practical points. Thank you very much for both of you, Murthy garu and Ramchandra garu. Thanks a lot.
Not only AP, sir, whole logins were 504.
Great. That's it.
Today,
All the states are getting benefited.
Today I got a call from Dr. Anandan Porur, and then all his postgraduates in Chennai, they are joining, they joined in this. I
Good.
believe that. So, very nice.
Thank you, sir. My special thanks to Glow Dharma for giving the technical assistance. Thank you on and on.
Right.
Thank you.
So,
Thank you,
bye-bye.
ma'am. Thank you.
Bye-bye. Right.
Sare, ma.
Thank you, sir.
Balu.